Statins, molecular mechanisms and clinical applications in cardiovascular disease. Statins represent a cornerstone class of medications that reduce cardiovascular disease risk through inhibition of cholesterol synthesis. This article explores their mechanism of action, clinical efficacy, and role in modern preventive medicine. Introduction to statins and their importance. Statins have become one of the most widely prescribed medication classes worldwide, fundamentally changing the approach to cardiovascular disease prevention and treatment. These powerful pharmaceutical agents work by reducing the amount of cholesterol produced within the body, thereby lowering circulating lipid levels and reducing the burden of atherosclerotic disease. The introduction of statins to clinical practice marked a significant advancement in our ability to manage dyslipidemia, with decades of clinical evidence supporting their effectiveness in reducing heart attacks, strokes, and cardiovascular mortality. Understanding how statins function at the molecular level, their clinical applications, and their role in different patient populations is essential for healthcare providers and patients alike. The molecular basis of statin function. Statins exert their therapeutic effects through a highly specific mechanism targeting a critical enzyme in cholesterol biosynthesis. The key enzyme involved is HMG-CoA reductase, which catalyzes the conversion of 3-hydroxy-3-methylgluteryl coenzyme A, HMG-CoA, into mevalonate, an essential precursor molecule in the cholesterol synthesis pathway. By competitively inhibiting this enzyme, statins effectively reduce the production of new cholesterol within hepatocytes and other cells throughout the body. This inhibition is highly selective and reversible, allowing for fine-tuned control of cholesterol production. The potency of statin inhibition of HMG-CoA reductase is remarkable, with binding affinities that far exceed those of the natural substrate, making statins extremely effective at suppressing the enzyme even at relatively low concentrations. Cellular and systemic responses to statin therapy. When statins reduce intracellular cholesterol synthesis, cells respond through a compensatory feedback mechanism that increases the expression of low-density lipoprotein, LDL, receptors on the hepatocyte surface. These receptors bind circulating LDL particles from the bloodstream, allowing cells to absorb cholesterol from the blood rather than relying solely on de novo synthesis. This dual mechanism, reducing cholesterol production while simultaneously enhancing its clearance from circulation, results in substantially decreased serum LDL cholesterol levels. The magnitude of LDL reduction varies depending on the specific statin used, its dosage, and individual patient factors such as genetic predisposition and dietary habits. Beyond their primary lipid-lowering effects, statins have been observed to produce additional beneficial effects on vascular function, inflammation, and plaque stability, contributing to their remarkable cardiovascular protective properties. Different statin types and their pharmacological profiles. Key points: hydrophilic statins, pravastatin, rosuvastatin, have more limited tissue penetration and primarily work in the liver, making them potentially safer in certain populations. Lipophilic statins, simvastatin, atorvastatin, levastatin, distribute widely throughout the body tissues and may have broader systemic effects. Potency varies significantly among statins, with high-intensity statins like atorvastatin and rosuvastatin achieving greater LDL reduction than moderate-intensity options. First-generation statins, levastatin, pravastatin, require hepatic metabolism for activation, while newer statins are already in active form. Clinical evidence supporting statin use. Decades of clinical research have established that statins significantly reduce the risk of coronary events, strokes, and cardiovascular death across diverse patient populations. Large randomized controlled trials have demonstrated that intensive statin therapy produces superior cardiovascular outcomes compared to standard dosing in patients with established heart disease. For primary prevention in individuals without prior cardiovascular events, statins reduce the incidence of first-time heart attacks and strokes, particularly in those with elevated calculated cardiovascular risk. The benefits appear to be largely independent of baseline cholesterol levels, suggesting mechanisms beyond simple lipid lowering contribute to the protective effects. Meta-analyses combining results from multiple clinical trials have shown consistent reductions in major cardiovascular events, reinforcing the class effect of statins across different formulations and patient demographics. Primary prevention, screening and patient selection. Initiating statin therapy for primary prevention requires careful assessment of individual cardiovascular risk using validated prediction tools that incorporate age, blood pressure, smoking status, diabetes history, and family history. Guidelines recommend calculating absolute cardiovascular risk over 10 years to guide treatment decisions, reserving statins for those with meaningful risk that justifies medication initiation. Lipid panel testing provides essential baseline data, though the decision to treat is increasingly based on risk scores rather than cholesterol levels alone. Lifestyle modifications including dietary changes, weight loss, exercise, and smoking cessation should be implemented concurrent with or before considering pharmacological therapy. Healthcare providers must engage patients in shared decision-making, discussing both the potential benefits of cardiovascular risk reduction and the possibility of side effects, ensuring informed consent before starting treatment. Secondary prevention and acute coronary syndromes. Patients with established cardiovascular disease, including those with prior myocardial infarction, unstable angina, or stroke, represent a group in whom statin therapy is unequivocally beneficial. For these individuals, high-intensity statin therapy is typically recommended to achieve aggressive LDL cholesterol targets, generally below 70 mg per deciliter or even lower in some high-risk situations. In the acute setting of myocardial infarction or acute coronary syndrome, statin therapy should be initiated early, ideally during hospitalization or immediately upon diagnosis. The anti-inflammatory and plaque-stabilizing properties of statins appear particularly important in the acute phase of coronary events, where they may limit the extent of myocardial damage and reduce complications. Long-term continuation of statin therapy in secondary prevention is associated with improved survival rates and reduced recurrent event rates, making adherence to this therapy crucial for long-term outcomes. Comparison with other lipid-modifying therapies. While statins remain the most effective and widely used lipid-lowering agents, other drug classes address different lipid abnormalities. Fibrates, for example, primarily target elevated triglycerides and low HDL cholesterol, addressing lipid patterns that sometimes persist even when statins adequately lower LDL cholesterol. Although fibrates demonstrate some cardiovascular benefit in specific populations with markedly elevated triglycerides and reduced HDL, the evidence base remains less robust than that supporting statins. Other emerging therapies including PCSK9 inhibitors, ezetimibe, and inclisiran target additional mechanisms in cholesterol metabolism, often used alongside statins for synergistic LDL reduction in difficult-to-treat patients. Lifestyle interventions, particularly dietary modification and regular physical activity, complement pharmacological approaches and remain essential regardless of which medications are prescribed. The selection of lipid-modifying therapy should be individualized based on the patient's lipid profile, cardiovascular risk, tolerability, and response to initial treatment. Adverse effects and safety considerations. Key points: muscle-related side effects ranging from mild myalgia to severe rhabdomyolysis represent the most clinically significant adverse effects, occurring in a small percentage of patients. Elevated liver enzymes can occur but typically resolve despite continued therapy, with actual hepatotoxicity being rare. New-onset diabetes has been reported with statin use, though the cardiovascular benefits typically outweigh this risk in most populations. Drug-drug interactions are important considerations, particularly with medications metabolized through the cytochrome P450 system. Improving adherence and patient outcomes. Despite the compelling evidence supporting statin therapy, adherence rates remain suboptimal, with many patients discontinuing treatment within the first year. Common barriers to adherence include perceived side effects, difficulty with once-daily dosing regimens, cost considerations, and lack of symptom perception from a silent risk factor. Healthcare providers can improve adherence through clear communication about the long-term benefits of therapy, addressing specific concerns about side effects, and simplifying medication regimens when possible. Regular follow-up appointments allow for monitoring of tolerability and efficacy, with adjustments made as needed. Discussing cardiovascular risk reduction in concrete terms, such as the number of heart attacks or strokes prevented, can help patients appreciate the value of continuing therapy even when they feel well. Patient education materials, reminder systems, and involvement of pharmacists in medication management can all contribute to improved adherence and ultimately better cardiovascular outcomes. Future directions and emerging research. Ongoing research continues to expand our understanding of statin mechanisms and identify opportunities to optimize their use. Investigation into genetic factors affecting statin metabolism and response may enable personalized medicine approaches, tailoring therapy based on individual pharmacogenomic profiles. Studies examining the effects of statins on specific inflammatory markers and vascular biology are revealing additional pathways through which these drugs exert protective effects. Novel formulations and dosing schedules are being developed to improve tolerability and convenience. Combination therapies using statins with complementary lipid-lowering agents show promise for achieving more aggressive cholesterol targets in high-risk populations. Long-term studies continue to clarify the role of statins in various special populations, including the elderly, those with chronic kidney disease, and patients with specific comorbidities. As our molecular understanding deepens and clinical evidence accumulates, statin therapy continues to evolve as a cornerstone intervention in cardiovascular disease prevention and management. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.